both the family physician as well as the specialist physician lead and project manager joining us here today. So please welcome to the stage Dr. Hoverman, Dr. Sandra, Allison, and Kirsten Schuld.
Hello everybody, I'm Sandra. I'm a public health and preventive medicine specialist. I'm also a family physician in Nanaimo. I'm really pleased to be here with our team. It's been a wonderful journey together, and I'm going to start us off. So, social connection and a connected community are foundational for human well-being. Loneliness and social isolation have proven to be as unhealthy for you as smoking and sedentary behavior. Hopefully that's not a surprise. Over the pandemic, we've seen more isolation, more loneliness, and more poor health as an outcome of this isolation. During this time, I've noticed that physicians have become not only medical stewards, but also social stewards for some of their more isolated patients. It's worth noting that the United Kingdom is ahead of us in many ways. Prior to the pandemic, they had appointed a minister of loneliness, and social issues were being identified earlier, and they had systems developed for helping people with their social needs as part of day-to-day clinical work. In Nanaimo, we've drawn from this experience in the UK, and we are leaning heavily on the expanding social prescribing efforts in the province of BC. The United Way is the appointed backbone organization in the province who is implementing social prescribing in our province. And this has been over the last 2 to 3 years. Our project team focused on our efforts on enhancing the relationships and strengthening the network of providers in the Nanaimo area towards a social prescribing system. With an intentional system, shared local goals and values, and a strong sense of collaboration, we created a coalition of the willing. Our coalition has sought to create a local social prescribing system across multiple stakeholders. Our collaboration has allowed us to demonstrate the effectiveness of meeting people's social needs outside of the clinic. Before we get too far, it's important to describe social prescribing and ensure that we're speaking about the same thing. Social prescribing happens when a healthcare provider identifies social needs and refers a patient to an expert, like a link worker, who can assess, arrange, and follow up for a patient's non-medical health needs. Largely based on the social determinants of health, link workers can offset the health system pressures of people who have not had their non-medical needs met.
You'll see here there's a Slido. For those who have Slido on their phone, could do the QR code. We're asking just a general poll of those who are familiar with social prescribing as it stands in the moment in your local context. I'll let you all do the poll while continuing with the presentation. So, here we are. Yes. Oh, the no's outweigh the yeses. It's nearly breakneck, half and half. Far more have not than have. That's really helpful to know as we take a pulse in the room. So social prescribing fundamentally is a health system strengthening intervention to both improve health and healthcare as the goal, resting firmly on the WHO's definition of health, complete physical, mental, and social well-being, not merely the absence of disease or infirmity. It also widens fundamentally patient-centered team care and makes standard work of asking the question everywhere, all the time, what matters to you? In this way, the health strengthening work fundamentally relies on learning from other countries, as Sandy's mentioned. Social prescribing in Canada has adopted from the National Health Service in the UK and the National Academy of Social Prescribing, and the establishment of the Canadian Institute for Social Prescribing at the University of Toronto, and with a firm foundation of funding and lessons from other numerous peer countries, addresses the paired epidemics of social isolation and loneliness. To keep as our aim improving, as we learned earlier today from Eugene, the accessible, respectful, safe, timely, effective, efficient, equitable, and most importantly, patient-centered care. Long before the 2023 Surgeon General's report, however, Michael Marmot and others in the WHO Commission on Social Determinants of Health made it clear, as Shirley was mentioning earlier, 75 to 80% of our long-term health and well-being is fundamentally determined by non-medical factors. Knowing this, what do we do? Yes, it helps to have the Surgeon General's report guiding the way. We can look back to 1964, associated lung cancer and cigarette smoking. Now we have a similar report this past year to guide our path forward with a strength of evidence. So as I said, this is a movement built upon a movement. What matters to you? It's really a relevant question, as they say in patient safety circles, and every time, an always event. Asking the question what matters to you should be an always event. Allowing us to widen patient-centered team-based care to bring that question to everyone on the care team. But more importantly, asking how do we respond to that question in meaningful, longitudinal, useful, life-saving ways. So the WHO provided our team this terrific toolkit that I'd say comes back to asking, how does health for all happen? And that in our present era, social prescribing is a way formed around this model that has in the center a link worker, as you'll hear more about in just a moment. But in this triptych of sorts, a bit of an homage to the Renaissance art piece, we sit with the challenge of having the patient who arrives to the one who accesses at the primary healthcare provider's door, the need to build that bond and trust, to pass off and do a smooth transfer of relationship to the link worker that then goes with to the community-based settings and ideally returns to the primary healthcare setting with feedback to close the loop and further apply that PDSA model of improvement mindset for further improving the social care. Now over to you, Kirsten, for how this developed.
So, depending on what social prescribing is, I'm going to speak to the specifics of our Nanaimo project. Our project was developed as a partnership between the Nanaimo Division of Family Practice, Island Health, the City of Nanaimo, and Vancouver Island University. Our steering committee was made up of representatives from each of these organizations, all with a commitment to bring social prescribing to Nanaimo. The division in Island Health supported the program through primary care and community health services, the city through Parks, Recreation, and Culture Department and their seniors programming, and VIU and faculty from recreation, tourism, and nursing, supporting the program with practical students and research. Our project aim statement guided us in our development and implementation. The aim statement is the social prescribing project will enable Nanaimo primary care providers to connect socially isolated patients with a link worker, who will then provide personal patient support with the goal of decreasing detrimental health outcomes associated with social isolation and loneliness. We settled on seniors to start our project with the hope that eventually we can expand to more patient populations. We received full project funding in October 2023 for 24 months, and our first priority was finding a link worker. Who should this be? Who would hire them? What should their qualifications be? Our partners at Island Health were able to hire a recreation therapist who could work within community health services as our link worker. We developed our own training manual, did some interviews, and hired someone passionate and enthusiastic about bringing social prescribing to Nanaimo. So now we had a link worker, and we had developed a referral pathway. A provider would use their clinical judgment and refer a senior needing increased social support. The link worker would meet with the patient and develop a plan to increase their socialization and connections. Our program objectives align with the City of Nanaimo's strategic plan, A Healthy Nanaimo for All. As the city was a key stakeholder, we wanted to prioritize our referred patients to be involved in city activities that were offered: Scrabble, pottery, chair yoga. But these classes cost money, which would be an additional barrier for patients. So we applied for and received 3 grants to fund our patient activities: the City of Nanaimo Community Development Grant, the Island Health Community Wellness Grant, and a Coastal Community Grant. This was enough to fund activities for all referred patients for approximately 1 year, and a kitchen social, which Dr. Allison will speak about in a second. In Just when you were ready to start, in came United Way. United Way is spearheading social prescribing across BC, partnering with nonprofits and funding link worker positions. They call them community connectors. So United Way partnered with Nanaimo Family Life Association, a nonprofit in Nanaimo, and funded a second link worker. They were eager to work with our project and gain participants from physician referrals. This is what makes this project quite unique. It's the intersectoral relationships between all these organizations. We combined our resources, knowing we reach more people. But how do we get started concurrently? We needed a pathway to direct and streamline all our referrals. So we developed one. We created an Island Health referral pathway within their existing system to direct and streamline referrals, enhancing the sustainability of this program. Now, this is a very busy slide, but it highlights the process of this project. The end result was that all referrals went into an Island Health centralized access system where patients were assessed for appropriateness, and then depending on their level of complexity, they were either referred on to our Island Health link worker or the Nanaimo Family Life community connector. Having patients be part of this centralized access system in Island Health was key to our program and ensured further sustainability. The referral process was built into an existing structure and enabled increased support for patients because central access was part of community health services, which can provide supports such as home care, mental health, etc. This provided a safety net for referred patients for Nanaimo Family Life and our link worker if patients needed it. We've been piloting this since June. It's going great so far. And Sandra's going to tell you a little bit more.
Thanks, Kirsten. So once we had all the pieces in place, it was really an exciting time to bring patients on board. And we had some early adopter physicians because when we were running into some of the, let's say, bureaucratic hurdles, patients who were already connected to the system were quickly referred onto the program. And through that, our community connector and link worker have done amazing work in trying to strengthen people's social health muscles. They've created space where they come together in a larger group, but on an individual basis, the link worker or the community connector meets one-to-one with people, sometimes in their home, to explore for people what's important to them and take them physically into the community settings that that patient is interested in. One specific example, our link worker had made a phone connection with the patient. She didn't have a lot of trust for the health system. But over a few phone calls, she became more trusting of the person that was reaching out to her and actually built a sense of friendship or connection to this person. And our link worker was invited to the home. And when she came into the home, there were a number of things in the home that triggered our link worker to ask more questions. What are the things that interest you? Look at these books. Tell me about this. And through these conversations, the lady revealed she had an interest in playing euchre. So our link worker found a place for this lady to play euchre and took her there. And she got to do what she wanted to. That made a huge difference to her state of mind, her feeling of mental wellness, her quality of life. These are just one example. Patients have said, I had no idea it was this easy to feel good, right? Making those small connections in community. So for my, benefit, I guess, being involved in this project has given me a sense of, let's say, accomplishment or that we've done something for people. And it's really interesting that you work in health and think that you make a difference for people, but it doesn't happen that easily. We do have kitchen socials. They happen every 2 weeks. It's an initiative brought forward by one of the ladies who said, you know what, we used to get together and we'd cook together and we'd have meals. So at one of the recreation facilities that has a kitchen, the team brings some of the patients, some of the clients together, community members, usually a dozen or more, and they get together and the food is provided by Nanaimo Food Share, and they cook and they play games and do puzzles, and then they take some food home with them. And so this is really just building community. Some of the people who've come in as, let's say, just people that are needing social connection are actually becoming volunteers in the program and carrying that forward and encouraging others to start volunteering. It feels like a little bit of a snowball effect.
All right, so keeping an eye on the time, I'd like to offer one more Slido. see what has been motivated in the last 15 minutes in all of you. Imagining, as you're opening the Slido, that you might have met a new friend today, or turned a stranger into a new friend in the room, at your table. Recognizing that as you leave this room, you'll have an opportunity to do the same. Speak to someone on a bus that you might be taking transit on the way home today. Or thinking about how to welcome in those who might appear disconnected in your daily existence. But even more so into, I think, the core of why we're here, talking about the vital aspects of partnerships, thinking right now about what partnerships you all might have to help establish such intersectoral, interstitial connections in your community for this to carry forward across the province. So here's our response to the Slido. Thanks to our Slido magicians in the back. Do you feel moved, inspired to champion part of the development of an intersectoral social prescribing partnership in your community? 99%. And that 1%er, let's chat. I'll be your friend. All right, with that, we'll turn over to questions and our brief reflection on lessons and asks. It is about partnerships, the interstitial spaces of your days and organizations between spaces of care and spaces of community. There is a need everywhere. We know this vitally, prior to the pandemic and more urgently following. And that finding sustainable streams for funding will be how we maintain that vitality of those connections going forward. But I think most importantly, it's trust and relationships. So with that, I offer it back to you. Questions? Up in the front row. Thanks.
First of all, I want to congratulate you. I think it's an excellent project. I am really inspired by it. I need to say that. The only question I have is that the problem now, mostly the people who are isolated are around my age or older than me, and the new systems are now, everything is electronic, for example. I live in Surrey and I have to go to any kind of social activity, and if I have to register it, if I don't do it within the first 5 minutes, it's all gone. So I'm not sure how you tackle that situation in your area.
That's a great question. We have some stuff in place. We're experiencing the same thing in Nanaimo, right? You gotta get up at 4 a.m. to register your kids for swimming lessons, or you don't get in. What we're seeing is we create our own thing. So we created these kitchen socials to accommodate some patients. There is a lot of space in the programs that we find people are interested in. So if you're interested in Scrabble, there is a Scrabble class. It was the funding more than the space and the need for it. So I think that we're tackling that. I think as the program expands, the city's been really great at working with us, saying if there's a class that you're seeing a lot of people wanting to be in, let's look at expanding it, and we're working together with them.
I just want to highlight two key pieces in response to that question. Yes, the digital divide is growing by the minute, perhaps. And yet, the conducive environment we have in Nanaimo, and I'd be keen to share this question in the municipalities that you live, is that a strategic plan was developed at present, 2023 and 2026, that has a healthy Nanaimo at the center of it. So I think it's both the built environment, the physical environment, and the social environment that helped make this uniquely conducive in Nanaimo. Perhaps your communities as well.
First of all, congratulations on this amazing work. I'm wondering, in addition to the social connections and the community partnerships that you have established, what is the level of integration of your social worker with the local PCN? And the other question that I have, more operationally, what was the process that you developed in order to ensure that the home visits are secure for your community league worker?
Awesome, great questions. First one we're working with, looking at expanding this possibly into the PCN. So far we've talked to social workers about it to make sure like there is some overlap, and that's a good thing, right? We can help the social workers that are very overburdened right now, and looking further ahead at further opportunities with PCN.
Thank you. And just with respect to the safety of people doing home visits, because of the mechanism of having people registered through our community health services, people go through the initial RI assessment and have some of those safety features kind of prescribing as a work plan agenda item. And so because they prioritized that in their work plan, it made it much easier to provide the community and like physician community support for social prescribing. So it's been a really nice synergistic relationship. One more brief one.
Okay, I think we have one more.
Thanks for that. Good work. Good work. My question is, like, knowing that the funding is not very consistent sometimes, and some of my own aspect of them is like, when you have these new programs get initiated, great results as demonstrated, do we have a feedback mechanism to show like when their funds run out, when there is no longer such an ability to continue these programs? Is there a detrimental side effect that can come out from it? And is there any actual evaluation that can be done to demonstrate side effects?
Thank you, that's a great question. I think one of the things that we observed from our city colleagues and municipal partners is that there was a bit of a mismatch between programming that was being delivered, people not always attending, and so really trying to realign and reorient some of the services and investments that we've made towards what people need and want. And so I think that to me has been demonstrated again and again by the city staff that we have sometimes programs where people just aren't attending, and so how do we understand what's being used and what's not? We haven't thoroughly built an evaluation plan for the project because we have evaluative components related to shared care only and physician engagement. But I think this is next level to really build that effectiveness. Thank you.
All right, hands together for this group.